Thank you for joining me for this session on maintaining anticoagulation efficacy and safety during the COVID-19 crisis. The question I'll be focusing on is whether you should be switching your warfarin patients to a DOAC. My name is Helen Williams. I'm a consultant pharmacist for CVD in South London. I'm also a member of the Primary Care Cardiovascular Society Committee. So why should we be worrying about anticoagulation? There's obviously a general workload related to INR monitoring. In the current climate of COVID-19, we're trying to reduce the pressure in the system and release staff to focus on more pressing matters. There's also infection risks to patients and to staff from the regular attendance at anticoagulant hubs for the INR monitoring. We're also going to see increasing numbers of patients infected with COVID-19 or self-isolating with their household or socially distancing or shielding, and these are likely to pass the burden of INR testing to community nursing teams who will not necessarily have the capacity to respond to the increased demand. We should also remember that infection with COVID-19 itself is likely to have a detrimental effect on the control of INR with warfarin. NHS England have produced a specialty guide on anticoagulant service during the COVID-19 crisis, and there are a number of things that this guide focuses on. One is the opportunity to switch appropriate patients from warfarin to DOACs, thinking about reducing the frequency of testing of INR to a maximum of 12 weeks, if it's appropriate. This may need to be extended by 2 weeks if symptoms of COVID are present at the time the test is due. The opportunity to utilise INR self-testing with CoaguCheck devices, minimising the risk of infection when testing for INR, so making sure social distancing arrangements are in place, hygiene in hubs, taking a one-in, one-out approach, or maybe thinking about drive-through services to avoid patients even needing to leave their car. There's also the need for appropriate PPE for staff. We also need to take account of the burden on community nursing services as a result of COVID-19 and think of things we can do to minimise that burden related to anticoagulation. Switching of warfarin to DOACs is one important element of the NHSE guidance, and a number of societies, including the Primary Care Cardiovascular Society, have come together to develop guidance to support people who are making the switch from warfarin to DOACs. There are two key priorities that I just wanted to highlight. Is one, that ideally this should be managed by whoever normally manages the patient's anticoagulation. So we shouldn't be expecting clinicians with little experience to take on anticoagulation switching. We also, and really importantly, we need to protect the supply chain. We've got hundreds of thousands of patients already taking DOACs. If we switch an additional 200,000 patients from warfarin to a DOAC overnight, then it's unlikely that the supply chain will be able to cope. We need to take a phased approach over the full 12-week cycle of INR monitoring for warfarin. A patient that doesn't need an INR till June doesn't need to be prioritised for a switch in this particular month. So do take a phased approach to allow the supply chain to cope. Important to focus on who should not be switched. While we're talking and thinking mainly about patients with AF and venous thromboembolism, they can also have coexisting conditions. So we must not switch people who have prosthetic mechanical valves, known moderate to severe mitral stenosis, antiphospholipid antibody syndrome. If patients are pregnant, breastfeeding, or planning a pregnancy, I wouldn't expect them to be on warfarin for a start. And we should be thinking of alternatives like low molecular weight heparins for these people. If they're requiring a higher INR than the standard INR range of 2 to 3, because patients with those higher INR ranges have something else going on other than simple AF or VTE. Patients with severe renal impairment, so creatinine clearance is below 15 mils per minute because DOACs are contraindicated. If patients have active malignancy or receiving chemotherapy, I would expect their anticoagulation to be managed by the haematology or oncology team. So if you're thinking of switching, I would consult with them. Important to check for interacting drugs. The SPCs for each individual drug has the full list. but I'm thinking particularly of patients who may be on drugs for HIV or anti-epileptics, but that is not exhaustive. If patients are on triple therapy, and by triple therapy I mean dual antiplatelet therapy, maybe aspirin and clopidogrel, and warfarin. In these cases, I would recommend discussing this with an anticoag or cardiology specialist who will advise, particularly on the dosing of the DOAC and the durations of each element of the triple therapy. And just a reminder that there's little data on the use of DOACs in patients with venous thrombosis at unusual sites. So, for example, portal vein thrombosis, and you may want to seek specialist advice for this cohort. Important when switching to take into account the INR that the patient has as a result of their warfarin therapy. So you can take two different approaches. The SPCs for each individual drug recommends an INR at which you should start the DOAC when you've stopped the warfarin. So for apixaban and dabigatran, starting with an INR is less than 2, edoxaban starting when the INR is less than 2.5, and rivaroxaban starting when the INR is less than 3. To take an approach like this, you may have to repeat INR checks daily until the required INR for the DOAC you want to start is achieved. In contrast, the European Heart Rhythm Association gives more pragmatic guidance on when to start DOACs after stopping warfarin. So they recommend if the INR is less than 2, start the DOAC that day. If the INR is between 2 and 2.5, start the DOAC the next day ideally, or on the same day as stopping the warfarin. And if the INR is between 2.5 and 3, withhold warfarin for 24 to 48 hours and then initiate the DOAC. Remembering, of course, that according to the SBC, you could start rivaroxaban on the day the warfarin is stopped, according to the SBC. So what about the process for switching? Ideally, we do a lot of this remotely, but we may not be able to do everything remotely. We're going to need to check the patient's blood to assess the INR. So you may find already on the clinical system, there's recent UNEs, LFTs, and full blood count. Ideally, they should have been checked within the last 3 months. When the next INR is due, check the INR as normal, record the patient's weight, and if the bloods weren't available or they were unstable or have been unstable, you may want to repeat UNEs, LFTs, and full blood count. Calculate the creatinine clearance. It is essential to use creatinine clearance to decide on dosing of DOACs. You cannot use the EGFR. There's strong evidence to suggest if we rely on EGFR, we will under or overdose a large proportion of patients. So you must calculate creatinine clearance, and I would recommend you use the actual body weight of the patient in the creatinine clearance calculation. Prescribe DOAC at the right dose and advise the patient to obtain their supplies, and that might take a day or two depending on the medication arrangements locally, so don't assume that they're going to be able to pick them up within half an hour and immediately start the DOAC. Once they've got their medicines, advise the patient when to stop the warfarin and when, in relation to that, to start the DOAC. So if you're using the EHRA guidance, the INR should be less than 2.5 when the DOAC started. Provide written instructions to back up what you've discussed. Involve family members or carers if possible. There is obviously a risk that patients may take both warfarin and DOACs concurrently, and we need to ensure their understanding to prevent that. Obviously, take into account if patients are using medicines compliance aids to minimise risks associated with the filling of the DOAC box. Make sure you provide an up-to-date anticoagulant alert card so everyone's aware of what the patient is taking. And if the switch is undertaken by someone outside the usual GP practice, provide all the information a GP would need, indication, baseline tests and monitoring requirements to allow primary care to safely take over prescribing responsibility. Also remember to inform community nursing teams if you know that they've been either monitoring the INR regularly or maybe even administering warfarin on a daily basis to ensure no error occurs there. So that's a brief overview of the guidance. There is more detail in the documents. I'd just refer you back to the NHSE Specialty Guide, which is a overarching document covering many of the elements of anticoag service provision we need to consider in the setting of COVID-19. And then the specific guidance for safe switching of warfarin and DOACs. You've got the web link there, which is endorsed by the Primary Care Cardiovascular Society. So thank you for your attention.